Thank you. It's a great pleasure to be here today and to present the Jose Rizal Medal Lecture. I have no conflicts of interest. Jose Rizal was a famous ophthalmologist and pioneer who sacrificed his life for his beliefs, and I follow a tradition of many speakers since Dio Campo. So what I'm going to talk about is keratoconus, and I'm going to cover over 5 main areas, starting with the landmark paper of Nottingham in 1854. So if we look at the evidence base and consider misconceptions, there are several different levels of evidence. The top levels being largely meta-analysis of RCTs and prospective studies, and the least good evidence being level 5. So what would Sherlock Holmes make of this? The fictional detective was born in 1854 in Nottingham's paper, but he probably said expert opinion is the least reliable evidence, so some of what I say you may want to disregard. If we look at the evidence base, it's growing rapidly. In fact, there are more than 10,000 papers on keratoconus, and of these, the vast majority have occurred in the last 20 years. So what do we know? We know there are genetic and environmental causes. We know it probably is a non-inflammatory disease, but we'll discuss that more. It's a progressive corneal ectasia. There's increasing irregular astigmatism with visual loss. The end stage is high drops and scarring, and treatment includes transplantation and collagen cross-linking, but as yet, there is no cure. So I'm going to look at how we refine the diagnosis, mainly by a number of new developments. There's also the classic things we looked at, including astigmatism and refraction, scissoring, retinoscopy, reflex, and Munson sign and down gaze. We also look at slit lamp appearance with the classic signs here from some of my patients, including thinning and ectasia, Fox striae, Fleischer's iron ring, Rizzuti's sign, prominent corneal nerves, Descemet's tear, and of course, in your bottom right, severe high drops. Computerized corneal topography completely changed the way we look at keratoconus and other corneal diseases. A number of new indices occurred in the early 1990s, such as central corneal steepening, asymmetric inferior steepening, and asymmetry of central power, largely from Rabinowitz group. In subsequent studies, we found that 50% of relatives of those with keratoconus probably have abnormal indices in astigmatism. We further look in high prevalence groups, and we find that maybe perhaps 1 in 5 relatives are suspected to have keratoconus. Computerized corneal topography is involved into tomography, so 3-dimensional imaging. So we've moved from placebo into Scheimpflug and OCT modalities. These increasingly identify early disease. They're key in refractive surgery. They enable better keratoconus classification and reveal family abnormalities, as we've mentioned. These can calibrate disease progression, enable prognosis, and provide monitoring treatment of treatments such as CXL. Tomography versus topography, well, slit scanning techniques win out because they also add in the 3rd dimension of pachymetry and posterior elevation, as demonstrated in this study looking at suspect cases by Donald Tan's group. There are a number of indices. I'm not going to go into those in detail, but the Bell and Ambrosi enhanced ectasia display, the BAD indices, are very useful. And this looks at a number of parameters, puts them together, and integrates that data in an AI fashion. What about repeatability? We've got these devices, but can we use them in a widespread fashion? Well, we looked at 50 out of 50 subjects with keratoconus, and we found that the number of devices were actually quite disparate in what they measured, but they were internally consistent with high repeatability. So the bottom line is, if you're using an instrument to measure keratoconus, you should use the same instrument in the same patient all the time. Newer modalities include biomechanical assessments, such as those by ORA and Corvus ST. These are very pretty instruments that tell us an awful lot about the actual function of the cornea and have allowed us to develop new indices, but they cannot actually discriminate subtle keratoconus from the healthy normal eye. So although these biomechanical tools help us, understand keratoconus remain very much in the research realm rather than currently being a key clinical tool. Will artificial intelligence solve all our problems? Well, if you read the popular press, you would believe that. Artificial intelligence refers to the capability of computer systems to perform tasks that typically require human intelligence, such as learning, reasoning, problem-solving, and decision-making. This was written by an AI device 5 days ago. Will this solve the problem of diagnosing subclinical keratoconus? Possibly not yet. This Cochrane study looked at 54 articles evaluating detection of manifest keratoconus using other utilities. AI was pretty good, with a high sensitivity and specificity in the region of 98%, but accuracy varied, and the certainty of the evidence was low. 28 articles evaluated subclinical keratoconus. There was good accuracy, but sensitivity was 90%, meaning 1 in 10 cases we missed. Quite a problem if you're screening for refractive surgery. And the certainty of evidence was very low. So the authors concluded we weren't able to draw clear and reliable conclusions due to the high risk of bias, and particularly the unexplained heterogeneity of the results. In Cochrane Corner, we et al. Made a couple of observations. From keratoconus detection to innovative approaches in predicting disease progression and monitoring of risk factor, AI demonstrates immense potential to enhance keratoconus management. However, the present review highlights that the current landscape of AI research is marked by inadequate reporting and methodological limitations. So what about etiology? What have we learned over the last 171 years? I'll cover over these 3 areas. It's almost certainly multifactorial. It may in fact be the final common pathway for a number of different pathological processes. One of the variables is definitely genetic, and there are also several suspected environmental components. These integrate into a simple 2-hit hypothesis. You have a genetic predisposition, you have an environmental second factor which brings it out. This is why we have such a varied prevalence of keratoconus, varying from 8.8 to more than 50 per 100,000 in the larger established studies. In studies where we look at topography, it may be 1 in 30 have suspicious topography. And this variation in part is due to different diagnostic criteria, differing genetic predisposition, and differing exposure to cofactors. If we look around the world in this blurred map, we find that the average might be somewhere between 50 and 100. New Zealand has 50. But other areas have quite low counts, like Japan, 8.8. Whereas other centres have enormous levels, such as Iran and India, which may be partly affected by consanguinity. And other areas that are emerging with data still not fully established. In this study by our team, we looked at keratoconus over 24 months in New Zealand. We looked at almost 2,000 cases of a mean age of about 41. We found that the ethnicities were European, Maori and Pacifica, but Maori and Pacifica were overrepresented compared to Europeans. Mostly 2/3 were managed by contact lenses, and mean corrected visual acuity was good at 6.9. But Maori and Pacific pupils had the highest mean K and the highest, most severely affected eyes. So other than ethnic predispositions, what are the other inherited and systemic associations? Well, the common ones we should all know are Down syndrome, Marfan syndrome, Ehlers-Danlos syndrome, mitral valve prolapse, and Leber congenital amaurosis. A number of these are associated with eye rubbing. Therefore, we've looked at a number of genes, including those on trisomy, on chromosome 21. Candidate suspects include all these listed here, including 2 collagen genes, but none of these have actually been convicted as being a general cause. Why is that? Well, if we look at the first large-scale genome-wide association, the GWAS, of keratoconus, this looked at 4,500 cases and more than 100,000 controls. 36 loci were suspicious. Both dysregulation of corneal collagen matrix integrity and also cell differentiation pathways were identified as disease-causing mechanisms. Pleiotropy suggested that there may be common mechanisms affecting other corneal diseases, and we all know the association with Fuchs and keratoconus. Common keratoconus variants only explain about 12.5% of the genetic variants. But there is the potential for future diagnostic tests, but not currently. So in summary, in terms of the genetics, it's complex. It's way above my grade. The genetics are not Mendelian, but polygenic. The family history increases your risk sixfold. There's concordance in severity for monozygotic compared to dizygotic twins. Large studies have identified very many associations. Many loci and genes associated with biomechanical elements. Polygenic risk scores can be generated to give odds ratio. In the future, this may allow us to assess patients in terms of the longer-term risk. But getting back to misconceptions and old wives' tales, a widely held traditional belief that is now thought to be unscientific or incorrect. And this might have been Mrs. Nottingham speaking to her friend in 1854. Did you know that apparently eye rubbing can make you blind? When I was a registrar, I did not believe eye rubbing caused keratoconus or really had any role. I thought it was an old wives' tale. However, things change. We should all change. And at this study by Prof. Rizal, we looked at a number of factors. Obviously, ethnicity and consanguinity, we've already mentioned, are important for geographical variations, but also 4 key areas: eye rubbing, atopy, floppy eye syndrome, and contact lens wear are strongly associated with keratoconus, less so, but linked pregnancy and thyroid dysfunction. These first 4 factors actually induce ocular surface inflammation, and matrix metalloproteinases can be released, and this may produce keratocyte apoptosis, which I'll come back to. So Rabinowitz has looked at the genetics and various other factors, and he agrees on the genetic plus corneal mechanical effects, and actually states that the proposed mechanical trauma, such as eye rubbing, is a sine qua non for the onset of keratoconus and quite possibly its only cause. So we've imaged corneal microstructure in a number of ways, both in the lab and clinically by in vivo confocal microscopy. We find that the loss of cells is non-inflammatory. This suggests apoptosis as the mechanism in keratoconus. In a study by Nidra and our group, we looked at basal epithelium, anterior keratocytes, posterior keratocytes, and endothelial layers in a large number of keratoconics, and found the cell count was reduced in all layers. Also, the subbasal nerve plexus is reduced by about 50%. If we look at the nerve plexus, we find it's both abnormal in density and also in shape. If we take away the background information and look at the nerves and then superimpose them on a corneal power map, we find that the cone itself may be dictating some of that fragility and loss of the subbasal nerve plexus. And the loss of keratocytes is what makes the nerves more visible. Trevor Sherwin from Auckland reports that the results support the evidence for inflammatory pathway activation in keratoconus and a possible redefinition of keratoconus as a chronic inflammatory rather than non-inflammatory disease. If we look at this another way, look at epidemiological studies to identify associations between keratoconus and immune-mediated diseases. This is a large study, 2,000 keratoconics, more than 12,000 matched controls. It confirmed some novel associations, such as Hashimoto's thyroiditis, inflammatory skin conditions. It also confirmed known atopy associations, including allergic rash, asthma, allergic rhinitis. The authors recently concluded keratoconus appears positively associated with multiple immune-mediated diseases. Therefore, systemic inflammatory responses may influence the onset of keratoconus. How can we put this together in a cell basis or a molecular biology way? Well, what about cell signaling? Epithelium is traumatized and releases interleukin-1. Keratocytes have receptors for IL-1 that are 4 times greater than normal keratocytes. This releases more Fas ligand. Epithelial trauma also releases Fas ligand. This Fas ligand is also picked up by those binding keratocytes. And what do we get? We get apoptosis, or cell death, throughout the cornea. So in the last 5 minutes, I'm going to talk about the management of keratoconus under these layers. So what do we think we know? It usually commences in late puberty. It's a gradual or intermittent progression. It's stabilised in 40s. About 20% need transplant. Maybe some misconceptions there. Indeed, if we look at children, this is a large study of 100 patients aged 15. We find that progression occurred in 77% over a 3-year period. The eyes progressed in more advanced disease at presentation, and importantly, there was a higher rate of bilateral progression if at least one eye had severe disease at presentation. What about older patients, though? Well, this is a collect study. The mean curvature 8 years had increased by 1.6, but look behind the data, and we find that 24% had a 3 diopter change. That's significant, especially when the baseline age was 40. In this study, Aki Goko looked at the natural history of corneal topography in adults that had never worn contact lenses, only worn spectacles, were well corrected and had relatively mild disease. They were about 40. About a quarter showed some changes in 4 indices, but less than 10% and more than a diopter per year change. So even in these low-risk cases, keratoconus continues to progress. In this study, we looked at 100 eyes with end-stage high drops, and what did we find? We found that Pacific, but not Maori, are more commonly affected than Europeans. It occurred approximately 4 years after the diagnosis. There was a strong history of eye rubbing, but actually a negative history of family involvement. In a third of the cases, surprisingly, in a country with free healthcare, the patients had never seen an eye doctor or an optometrist. So what about the treatment options? Well, these are listed here, and most of them will be familiar to you, from conservative to more aggressive. In an early study we performed, we found that about 2/3 of patients are maintained in contact lenses, about 1/3 go on to penetrating keratoplasty, usually about 8 or 9 years after diagnosis. However, that changed a lot with the advent of corneal cross-linking, as Wallensack said in 2006, is this a new hope? Although the Cochrane cross-linking review in 2015 was less admiring, saying the evidence is limited due to lack of properly conducted RCTs, it did notice it had been adopted worldwide. If we look at a more recent review from our team, we concluded that the modifications of the original Dresden protocol work well. Accelerated protocols have shown comparative results, and although there are limited studies, it would appear that immediate sequential bilateral cross-linking is pretty safe. Generally, it's very well accepted, and the success rate in most studies is better than 90%. Of course, intercorneal segments are used in a limited fashion in eyes which have reasonable vision. It's safe with femtosecond lasers and can be combined with CXL. In terms of transplantation in Auckland and in New Zealand has always been heavily influenced by keratoconus. But if we look at the data since we introduced cross-linking in 2007, allowing there would be about an 8-year lag to see major changes, we found an immense drop in this study in the number of cases requiring corneal transplantation for keratoconus. Keratoconus generally do well with grafting, with a 90% survival at 10 years in low-risk cases, but the main failure is rejection. Of course, we do have a panacea for that, and that is DALK. The disadvantage is technically more challenging and may have financial issues in some centres, but the major advantage is preserving the endothelium. and avoiding allograft rejection. However, this has not been adopted as widely as one might have expected. There are emerging studies, which I'm not going to get into detail, which include CARES, interstromal lenticule insertion, and Bowman's layer transplant. But I'd like to finish in the last 30 seconds or so looking to the bright new future and summarising somewhat of what we have learned in this lecture. After 170 years, there is still no cure for keratoconus. Its genetics are complex, non-Mendelian, and only partly explain the disease. A two-hit hypothesis best fits with genetic plus environmental factors. Possible inflammatory elements may be there, and therefore atopy and eye rubbing should be treated. Tomography, OCT, IVCM, and biomechanics improve our understanding and diagnosis, but subclinical early cases still defy 100% diagnosis. AI has great potential, but it's not yet a diagnostic panacea. Contact lenses remain the mainstay of treatment. Crosslinking in its several forms typically stabilizes keratoconus now. Penetrating and DALK are still foreseen to be needed for the foreseeable future. Gene therapy is highly unlikely, but genetic diagnosis may highlight susceptibility to KC and therefore consideration of environmental factors. Cell therapy trials only number 3 and are still in their infancy. Only remains for me to thank the many, many individuals who have been involved in this research over 30 years and to the National Eye Bank of New Zealand, which provided much of this data. Thank you very much for this kind invitation, and thank you for your attention.